It's a real pleasure to welcome Mitchell Levy and Jay Schuur to this afternoon's presentation. As Jack stated, they've been key in our local responses and also have played roles in national and international responses to the pandemic. Jay Schuur is professor and chair of emergency medicine. He's been at Brown since 2018. He's expert in quality and patient safety and has a focus on innovation, which I'm sure has proven to be very useful to him in the last few weeks. Mitchell Levy is professor of medicine and chief of pulmonary critical care medicine at Brown. He joined the faculty as director of the medical ICU at Rhode Island Hospital in 1997 and became chief of pulmonary critical care in 2006. Through his work in the International Surviving Sepsis campaign, he's brought about a decrease in mortality for sepsis, and then recently has served on an expert panel convened by the National Institutes of Health to develop treatment guidelines for COVID-19. And this has figured very importantly in the news of late. So thank you again, Mitchell and Jay, and take it away.
Thanks, Sharon. And I want to thank the Dean for the kind invitation to Jay and I to present today. Our topic, as you know, is acute care surge planning for the pandemic. Here are our disclosures, as Sharon already mentioned. We don't have any financial disclosures. I do have an intellectual disclosure that I don't really know much about predictive modeling, but I'm going to give it a try anyway. This is the outline. We're going to kind of switch back and forth, Jay and I will. First, I'm going to talk a little bit about surge modeling for acute care facilities and predictive modeling altogether. And then Jay is going to talk about preparedness for emergency departments, and I'll follow with some discussion on the critical care surge planning that we did at Rhode Island Hospital and the Miriam Hospital. And then Jay's going to finish talking about preparedness for surge beyond the existing hospital structures. And then hopefully we'll have time, we expect to have time to open it up for question Q&A. So let's talk a little bit about predictive modeling. I pulled this from a New York Times website, and I think the confusion illustrated here really describes predictive modeling well. This is from April 6th, and Governor Cuomo mentioned that he believes that the number of coronaviruses in New York will hit its high point that week and then hopefully begin to drop. And then he very quickly acknowledged the uncertainty of that prediction. And you can see here the paragraph basically says that the projection models have a number of alternatives, and basically that some say that it's going to go up and some say it's going to go down. And that's pretty much what predictive modeling is. And I'm going to show you some examples in a moment of that for New York State in particular. This is just also, I wrote, I'm sorry, this is New York State, not New York City, but on the 24th of March, the projection from the modeling that Governor Cuomo was using to give his daily addresses predicted that there would be a need for 140,000 hospital beds and 40,000 ICU beds. And shortly that next day, I believe it was on the 25th, social distancing measures were initiated and in New York City and New York State. And 2 weeks later, so this is interesting, 2 weeks later, the actual numbers for New York State were about 18,500 hospital beds and only 5,000 ICU beds. So you can see right away the incredible difference in these numbers. And this is some of the models that this is also as of April 10th, I believe. You can see the number of 18,500. So this was as of April 10th. And you see here the various models that that the governor was working with. And this is the one that was predicting 140,000. This is the Institute for Health Metrics Evaluation that I'm going to talk about in a moment as one of the two models I'm going to talk to you. And here, consistent with IHME, you can see the big difference between what some of the models predict and the IHME models, which consistently underpredict the numbers. So why the need for predictive modeling? And I think, I mean, it's fairly obvious, so I'm just going to review it a little bit. In this particular case for COVID-19, predictive modeling was particularly necessary because it was a new virus. It was not able to be contained. And more importantly, for the predictive modeling, there was much more rapid transmission, both locally and globally, than either SARS or MERS over the past 5 years. And of course, there was no pre-existing herd immunity similar to SARS and MERS. And obviously, there was no proven vaccine or antiviral treatment. So for those reasons, public health decision-making for resource planning became rapidly uncertain, and therefore people turned to predictive modeling as a way to try to predict what resources would be needed. And the decision-making was based in part on the mitigation through social distancing rather than epidemiology. And that's going to be important as I describe some of the models as we go forward. The modeling was designed and utilized to forecast the demand for hospital beds, ICU beds, in particular ventilators, which as we know were in short supply in both Italy and in New York City, staffing needs, and probably more important than anything was try to predict somehow the peak demand and what that peak demand would be in terms of hospital beds, critical care beds, and the other things you see listed here. The idea of the predictive models is, and I'll show you this with the IHME, is to be fit for purpose and to be somewhat user-friendly, and obviously to inform local decision makers. But the important thing about the models is they differ very fundamentally in methodologic approaches and the degree to which they can be locally customized. So in the interest of time, and I must admit the limitations of my knowledge, I'm really just going to review two models, and they're the two most common models. The one that's probably received the most press, and the one that's most widely quoted is the Institute for Health Metrics and Evaluation, the IHME, and the other one that I'll talk about in a moment is the one that our Rhode Island Department of Health and other departments of health use for predictive modeling. The IHME is from the University of Washington, and most important about IHME is it's mortality driven. It's a mortality driven model, and I'll talk about that more on the next slide. The initial development of the IHME model for COVID-19 was developed first out of the mortality statistics in Wuhan, and then on April 5th, 8 more cities were added, and then on April 10th, only 5 days later, 19 cities in total were used for the development of the model, and there were cities in China, Italy, and Spain. And then on April 13th, some French data were added to the IHME model on older patients in both hospitals and skilled nursing facilities. The important thing about the IHME model is it basically uses mortality curves in cities that have already reached their peak to try to predict the peaks in other cities. And it derives hospitalization rates from hospitalization to death ratios. That's why it's a fundamentally mortality driven model rather than epidemiology and infectiousness, which I'll talk about in a moment. And from the hospitalization to death ratios, ICU and ventilator use is predicted by approximating the hospitalization prediction and using ICU utilization as approximately 25% of hospital beds. And that's how ICU and ventilator use are determined in the IHME model. In addition, over time, after Wuhan City, after the cities from the rest of China, Italy, and Spain were added, the model started including the mitigating effects of social distancing, including these 3 that you see here, which are school closures, stay-at-home orders, and non-essential business closures. So there was initially a 4th aspect of social distancing that was included, which was travel limitations. But because rapidly, globally, countries put bans on traveling, especially from China, Italy, and Spain, that was dropped in mid-April by the IHME model, and only these 3 methods of social distancing, metrics of social distancing was utilized. And there are real problems, and there have been a number of recent manuscripts published in Annals of Internal Medicine describing the problems with the IHME model. And it's important because the IHME model is, and I'll show you, I think most of you are already familiar. It's very sexy, it's easy to use, it's very user-friendly, and it's widely quoted, but there are a lot of problems with the IHME model that have been listed in the literature now. And you see a few of them mentioned here. The model assumes that the variation in mortality curves is captured by social distancing and applies everywhere equally. That is, that the impact and strength of social distancing applies everywhere equally, and obviously we know that that's not true. The approach generalizes mortality curves for every region, and the death counts, we know that death counts can be unreliable. That's particularly been talked a lot about in the literature and in the lay press about the death rates coming from China. So immediately you can understand that the IHME model is going to be seriously impacted and affected by the limited accuracy of the mortality rates being reported, not just in China, but in general in these countries. And we also know that, from the literature and from the lay press, there are a number of there's a percentage of unrecognized mortality from patients who are either not tested or who had died at home even after being tested. So the true mortality rates from COVID-19 still remain to be discerned. And also, if you've used the IHME model, you know that the uncertainty bands are really broad, but they're not obviously transparent, and you really don't see the confidence intervals around them. And I'll show you that in a moment. And finally, we know that the IHME model really projection revealed a lot of volatility, and we could see that from the New York City data that I showed you. The other model is the CHIME model, which is from the University of Pennsylvania, and that's the COVID-19 hospital impact model of epidemics. And this model is probably more accurate. However, it tends to overestimate. In part, it's accurate because it's a transmission and or mechanistic model. So it incorporates the host population into epidemiologic modeling and based on infectiousness. It also is the model that's used for the Department of Health, and it's a susceptible, exposed, infected, recovered disease model. That's the SEER model, and that's the one that's most widely used. You're going to see in a few slides as I get to it, the most important aspect of the CHIME model is the R0, the reproductive number, which is the number of additional cases one infection will generate. And obviously that's in the absence of mitigation. So as mitigation takes place, the R0 number changes dramatically. So the key model elements from the CHIME model is mitigation, as I mentioned already, the doubling time, which is the number of days for epidemic to double in cases, incubation period, which is the number of days from infection to symptoms, and the serial interview. The serial interview is the number of days between illness onset in the initial infection, and then how that changes in the secondary transmissions as the epidemic and pandemic progresses. In addition, there's exposure details, which is the degree and duration of infectiousness before and during symptom onset. And then of course, population density. And it's important to recognize that as I'm describing these model elements, the IHME model includes none of these. So the IHME model, part of its weakness is that none of these key model elements are included in any way in determining the peak hospitalization bed mortality and ICU bed utilization. So you can understand why the CHIME model is much more favored by departments of health in trying to predict how much resource utilization will be needed during peak. In addition, I should mention that CHIME also includes the regional populations at risk, including the regional population size, the hospital market share, and the currently hospitalized census as the model is built for each individual state or Department of Health. So most important to all of us is that summarizing all of these models, any reduction in the R0, which is the transmission time, through mitigation results in a flatter curve. And so a flatter curve means delaying the peak and lowering the likelihood of exceeding resource capacity. The problem with that, of course, is as you reduce R naught through mitigation, you also reduce the likelihood of herd immunity. And I know this is obvious to all of us, and we've been reading about it in the literature and in the lay press. And the price that we pay through all of these models for flattening the curve is reducing herd immunity, which, as most of you I think know, is when 70 to 80% of the population have either COVID or COVID-19 related antibodies. And because more patients remain susceptible in the absence of a vaccine, that increases the likelihood of resurgent waves. And we'll talk about that a little bit as we go along. So this is the IHME model. Now, this is a flat, it's not a website, obviously, so you can just see, but if this were live, I think most of you who've played with this know, you can move this bar here, and as you move, it changes the number of beds available, the number of beds needed, this is hospital beds, the number of ICU beds needed, the number of invasive ventilators needed, and the ICU beds available. What is really clear in Rhode Island, and this we'll talk about more as we look at the model, is this. So this, I believe I did this, this is as of April 25th. So I did this a couple of days ago, but you can see already this number is overestimated. And I will tell you that when we first started looking at the IHME model back in March, even the IHME model, which has consistently under-predicted compared to the CHIME model, the number of invasive ventilators predicted initially in late March by the IHME model was close to 300 ventilators, around 280 ventilators, and about 330 ICU beds needed. And we're still not at that point. And as you'll see in a moment, we're past surge. So the IHME model is not as accurate as the CHIME model, but even though it underpredicts the CHIME model, you can see that it's overpredicted the amount of ventilators and ICU beds we'll need in the state. This is data that was published based on April 10th and a screenshot from Governor Raimondo's news conference on April 16th. And up to that point, we in Rhode Island had not seen any decline in the hospitalizations. And at that time, the thinking was, and by the way, this is April 16th, right? This is 10 days ago or so. But it was based on data from the 10th to the 12th. And you could see here that this was the projections for Rhode Island. This is the projection April 27th was for 4,300 beds. And then on May 3rd, the need would be for 2,200 hospital beds for Rhode Island. And that translates into about 1,000 ICU beds and 860 ventilators. And that's important because as recently as last week, I've been on regular calls, daily calls for ventilator projections and ventilator accrual, and we were working with these numbers until just a couple of days ago. So just to finish my section, I will say that it does appear that the surge is past. It does appear that we flattened the curve. It appears that both Rhode Island and other states were able to flatten this curve with social distancing. At this point, as I just showed you, most COVID ICU patients are coming from the wards, and that opening up restrictions are likely to lead to another but flatter surge than we saw previously. And with that, I'll stop and turn it over to Jay.
Thanks, Mitchell. So I'm just going to take a second and talk about emergency management because surge planning falls into this greater discipline of emergency management, preparedness, and response. And the diagram on the lower left with the circle shows the cycle that professionals who think about this think about how to deal with disasters and other items like pandemics. And there are four elements: preparedness, response, recovery, and mitigation. Preparedness was really the distant past up until March 1st in this state when we had our first case. We're currently in the response phase, which is March until now. And we're all looking forward to the recovery phase, but that's still a time to go. The other thing I will point out is that a disaster occurs when a hazard impacts on a vulnerable people. And that vulnerability depends on how much capacity we have. Depending on the size of the hazard, in this case a pandemic, and the amount of capacity we have determines whether or not there's a disaster. And so preparedness, this first phase, are measures to build capacities. Today, we're talking about acute hospital capacities, so capacities in emergency departments, on hospital wards, and in intensive care units. And the thing that I would definitely take away from today is that this was not a surprise. There has been preparedness work for literally decades about pandemics. The items on the right of this slide all come from the government website around emergency planning, and you can see that one of the biological hazards is pandemic or infectious, such as avian flu. And so I'm going to talk a little bit about some preparedness that's happened in years prior, both SARS and H1N1 flu. We've also, at our healthcare facilities and in the state, done ongoing drills around Ebola and other types of disasters. These are things that prepare us to deal with these sorts of issues. We then had a more acute phase of preparedness from late January when the CDC and others made us aware about the spread of COVID until our first case in early March. During that period, institutions activated our incident command systems, and we developed and implemented our local plans. I will break out the response into two periods. These are somewhat arbitrary, but really from the first case in March until maybe 10 days or so, a couple weeks ago in early April. During that period, we went from having isolated cases to having widespread community transmission. During this period, there was very limited availability of testing. The infection control principles were rapidly evolving, both here at our institutions and nationally and internationally. And as Mitchell just pointed out, the hospital impact was growing and the peak was unknown. So during this period, there was a fair amount of uncertainty, and we were both responding and evolving our response. Starting a couple weeks ago, we've had much more availability of testing in the hospital. We've come to agreement on infection control principles, and the hospital surge has plateaued, so our response has been more stable. I'm going to talk for a second about SARS, the first global coronavirus pandemic back in 2003, because there are a couple of really important lessons that were learned out of this, particularly in Canada, a country with a healthcare system very similar to ours. And there were just over 8,000 cases worldwide. Canada had just less than 1,000 cases. And their experience, the main takeaway was that in-hospital transmission was a key source of infection. They learned early on that there was much more transmission in hospital than in the community. And they learned the importance of changing hospital operations to reduce nosocomial or in-hospital spread. They developed pods specifically for SARS patients, teams that worked in those pods, and they worked extensively on the right practices for using personal protective equipment. The picture on the right is from a SARS pod at St. Michael's Hospital in Toronto. It doesn't look that different from things you're seeing today. And the image on the top is actually the website from the CDC of the actual lessons learned from SARS. So there is a lot that was published about that. The second thing that was learned about SARS in Canada was what happens when you get a pandemic on top of an already crowded health system. The Canadian health system, like many parts of the United States, is usually operating at capacity. And so they had to do planning on what they would do if SARS spread and their hospitals were already full. And so they came up with plans to cancel elective surgeries to decrease people in the hospital and ways to treat patients at home. They also were forced to close some emergency departments due to infection control concerns. And the reason for that was that the physical way that their emergency departments operated didn't allow them to safely implement infection control procedures. And I'll come back to that in a minute as I talk about our responses. Next slide. The 2009 H1N1 pandemic also was an important preparedness event for coronavirus. For those who weren't in healthcare or don't remember, in April of that year, there were 2 cases in California that had no connection. And very soon after that, the CDC activated the Emergency Operations Center. There was wide-scale preparation across the United States. The CDC led preparedness across all sectors of the economy. The image on the right at the top shows the CDC website you can still access. And there are literally action plans for all different parts of the economy that were developed. Hospitals developed preparedness plans, and the hospitals that we work at and staff have those preparedness plans. And they include having different levels of spread of the virus, different amounts of the community impacted, and what actions would be taken at the hospital. And a big part of that planning was, again, actions to account for patient surge, because flu is thought to likely happen in the winter, although this was spreading in the late spring, at times when the health system is already quite full. And so we had this literally in our files and on the shelf as we started to prepare for coronavirus. Next slide. So in late January, when the CDC made announcements, there was, I think, certainty amongst healthcare professionals that COVID would spread to the United States. There were a number of uncertainties. It was not clear if the clinical presentation and symptoms would be an accurate screening tool. Back then, we were hearing about cases from China and other areas, but we didn't have a very good handle on what the disease itself looked like as it was presenting to healthcare facilities. There was uncertainty about transmission. Was this an airborne disease like tuberculosis that can rapidly infect a relatively large number of people in a space, or was it a droplet transmissibility more like the flu? And that difference determines infection control standards that we have to use in the emergency department, critical care areas, and other parts of the hospital. Also, what would the rapidity of spread be in the community? It's related to the transmissibility, but there are other factors, and that would affect how we would need to address it in the healthcare facility. And then, as Mitchell just pointed out clearly, there was a lot of uncertainty about what the acute hospital needs would be. Next slide. So I'm going to talk about what we have done in the emergency department and a little bit about EMS preparedness and response. Next slide. I think it's important to talk about how emergency departments were operating in January and February before COVID arrived, because that's the context onto which we had to make changes. Modern emergency department operations aim to get patients in front of a physician as soon as possible. Historically, all patients went through a long triage process with a nurse and then went to a waiting room and waited for long periods of time. In order to speed up treatment and identify patients who can benefit from time-sensitive interventions, for example, for stroke and for heart attack, many emergency departments, including the ones that we staff, have models that look like the flow on the right. There's a rapid evaluation when you arrive, but then you're as soon as possible gotten to see a physician, either in triage or in the main emergency department. And a determination is made about if that patient can be discharged, if they need testing, if they're so sick that they need to go to a special area of the emergency department. This has been helpful at helping shorten times to diagnosis and treatment for life-threatening conditions. And it's also helped us deal with the fact that many of our hospitals and emergency departments seem like they're always at or near capacity. So if we had that old system, patients would wait a long time before being seen and having any testing done. This is a picture of Rhode Island Hospital Emergency Department on a morning, early in the morning without any patients in the waiting room. You can see the walk-in entrance in the back. There's a greeter desk that you can't see, but that's where the nurse does a rapid assessment. And then the area on the right is the provider and triage area. And there are 6 small exam rooms there. And for much of the day, historically, we've had a physician there, a nurse there, and 2 medical technicians. And we rapidly can bring patients in, do the initial history and physical, begin testing, and determine where in the emergency department they need to go. The problem is this prevents a significant infection control problem. These rooms are small spaces. You have many people in there, and many people will contact the patient before isolation because the patient walks in, is seen at the greeter desk, may sit in the waiting room for a period of time, and then goes into the provider and triage area. So from late January until early March, as we were making our preparedness plans, we really followed the playbook for MERS, Middle East Respiratory Syndrome, another coronavirus, and some thoughts from Ebola, with our goal being to identify COVID patients by screening and then isolate them. We instituted screening of all patients on arrival, and use travel or contact with infected persons. And we updated the travel and contact information. At this point, there were no local cases. So, if the virus had spread to another country, we would update the travel guidelines that were screened for at triage. And if someone screened positive, that they became a person under investigation, or a PUI. They were taken to an isolation room, and maximum infection control precautions were used. A test was gathered, and the plan was that most of those patients would not be sick enough to need the hospital and could go home, be quarantined, because the test didn't come back for 2 days. If they needed to go to the hospital, specific areas of the hospital were identified that could have those maximal precautions. This strategy really assumed limited or no community spread. It assumed an isolated person coming in who we could screen. It required having fewer patients than we had isolation rooms, and this worked early on. It required either having adequate PPE to dispose of or having reuse procedures for PPE. And early on, when we had very few patients, we followed long-standing practices where we would don new PPE, we would see the patient, and then we would dispose of it, single use. And it was limited because the testing took several days at the beginning. Things changed in early March. There were 2 cases identified at the beginning of March in Rhode Island from a trip to Italy. And at the same time, we were watching what was going on in Massachusetts. And if folks remember, there was a conference at Biogen where a large number of individuals were present, and then it became known that a couple of attendees had tested positive. And so there was clearly community spread in Massachusetts, and we figured it was only a matter of time until similar things happened here. So the second phase of response, which we're still working on implementing now, is the idea of responding to community spread by identifying risk zones within the healthcare facility. This is also called traffic control bundling, and that came from healthcare facilities and researchers in Taiwan who are noted at the lower right. And the idea is that you screen and then determine areas and patients that are lower risk, moderate risk, and high risk, and you have different protocols and procedures for those different areas. We have made significant changes in our emergency department operations, and we continue to make them to try to get us to the state where we can really divide the levels of risk. So we've developed physical barriers between arriving patients and healthcare workers. That has made us pretty much eliminate the provider and triage concept because it was not possible to do that rapid flow of patients and do it safely when we need to screen patients and get them to areas where they can be divided between having COVID as a likely possibility or not. We screen patients to identify if they're COVID likely based on symptoms or contact with infected persons. If they screen positive, they get designated to a specific area in the emergency department that's being called a warm unit. In those areas, staff wear personal protective equipment continuously. Between patients, they change gloves and they sanitize hands. If they screen negative, they go to the regular emergency department, and PPE is worn on an as-needed basis based on the patient's symptoms and signs and other items. The biggest limitation is that screening is not perfect. We know that up to 40% of patients are likely asymptomatic. And so patients who come in with something that does not seem like it's from COVID, for example, someone who passes out and hits their head, could have COVID, and we have to be cautious. We still have testing limitations. The fastest turnaround time we're getting is around an hour, and sometimes it takes up to 6 hours, which means that in the emergency department setting, we have a significant amount of time when healthcare providers don't know whether a patient has tested positive for COVID or not. There has been a lot of work around personal protective equipment. As everyone who's heard the news knows, there are national shortages of PPE. This has required us to reuse PPE following CDC and WHO crisis standards. These are standards that exist when there's a crisis and we don't have the same supply we typically have had. And the hardest part about this, I think, has been messaging this, because for many years, we have followed a single-use approach with PPE. And now telling people to do something different leads to uncertainty and fear, and that's very logical. I think the infection control experts, and I have reviewed the papers, and I believe the guidance we're following, but it's hard to literally start dealing with a pandemic one way on at the beginning of March, and then at the end of the month change the practices around PPE. The second thing I'll point out is, in many ways, more important than the exact availability of PPE is how we use it. And you can see the image on the right showing a gap between the glove and the gown, and that's a problem. And putting the gown on correctly and then covering that with a glove will prevent that gap. And so having environmental cues and protocols are critical to reduce human error in PPE use. And so we've designated a pod in the emergency department where patients who screen positive for COVID go. There are physical signs telling staff to stop and put on the correct personal protective equipment, and we've had guidance for them on how to properly don or put on and take off that equipment. We've also looked at our operations around the highest risk procedures. Doing airway procedures such as intubation, when you put a breathing tube in a patient because they need assisted ventilation, is one of the highest risk procedures. And so we've used simulation to refresh all of the EM physicians on video laryngoscopy. And we also developed an airway box that you can see on the right that came from a physician in Taiwan who posted this on the internet. We had to do a fair amount of preparedness about staffing, and we thought, what would happen if there was a large patient surge, and what would happen if many of our healthcare workers were ill with COVID? Usually we have about 115 emergency physicians that staff the 4 emergency departments that we staff. We looked at prior months of national conferences and did some modeling, and we figured we could staff with about half that many physicians. The most interesting thing about this pandemic has been that a big part of our preparedness, preparing for what to do with the surge, has not really happened, because the graph on the right shows emergency department patient volumes from early March until today. And our volumes have dropped approximately 40%. So while we are seeing patients with COVID, we're not seeing so many patients that we are having issues with staffing or available rooms, et cetera. Finally, I'll touch on emergency medical services. This could get its own talk, but EMS response that includes ambulance, rescue, fire, police. are at significant risk. And I think it's important to point that out. In Rhode Island, there are approximately 80 EMS districts. There's a very varied baseline level of education regarding infection control across the staff. And each of those districts has to procure its own PPE. And so there are definite significant PPE shortages. You can also be aware that if you're doing a long transport in the back of the van that's pictured on the left, you have significant exposure to a patient, more so than we do in most of our rooms and healthcare facilities. Our faculty have been very active with multiple efforts to educate and disseminate best practices with state and local EMS agencies. A concern of EMS is that they would be called to patients with COVID who do not need hospital care. And this is important because it presents a risk to their staff in terms of contact and also during the transport. And it also means those ambulances are out of service for often over an hour because they need to be cleaned. And so we've collaborated with Rhode Island to develop a protocol for non-transport. Once an EMS crew gets to a scene, if they feel comfortable that the patient does not need to go to the hospital, they can call an emergency physician, review the case, review the vital signs, and get the physician's approval to not transport the patient. We also are doing a pilot project with televisits with an EMS agency. I'll turn it back over.
Thanks, Jay. So in the interest of time and allowing question and answers, I'm just going to just take a few minutes and show you what the surge for lifespan critical care was. I saw Cap Powell's presentation last week, and so I don't feel the need to show you. He did a really nice job of showing all the external adjustments that were made in the ICU to create negative airflow rooms and HEPA filters in each room. This is just to show you what we planned on for turning our current 18-bed medical intensive care unit at the Rhode Island Hospital and the 16-bed intensive care unit at the Merriam Hospital into a COVID ICU. We had several tiers that included planning for the fellows and changes in attendings. And just to make a long story short, by April 8th, we reached a fully filled COVID medical intensive care unit at Rhode Island Hospital, and about eight beds in the Merriam Hospital intensive care unit. So about April 8th or so, we opened our second COVID intensive care units at Rhode Island Hospital. And this is the current working plan, just so you see. We were asked by the state Department of Health to develop a critical care surge plan for lifespan for just Rhode Island Hospital alone that would allow for 300 critical care beds. And just to keep us in a context, we currently have about 105 critical care beds in the Rhode Island Hospital. So they asked us to triple our critical care beds. And you could see here, essentially what we did is convert all of the step down and intensive care units to critical care unit, COVID critical care units. So after the medical intensive care unit, we had a COVID and a non-COVID medical intensive care unit on the 4th floor of the Rhode Island Hospital, and then went to the 5 step down unit on the 5th floor, which is across from the SICU and TICU, which has 16 beds. And that 5 ISC is currently filled. And so about 8 days ago, we pulled the trigger and went to our next COVID ICU, which is the neurocritical care unit. The neurocritical care unit we were easily able to split that into 9 beds of COVID intensive care unit and a 9-bed neurocritical care unit. And then on Friday, which is the 24th, correct? Yeah, I think the 24th, we actually made the decision to open up the rest of the neurocritical care units. And we are now at 12 beds in our COVID neurocritical care unit, which is not really neurocritical care. It's just simply a COVID intensive care unit. We have 15 beds in the COVID 5th floor ICU and 15 beds in the COVID medical intensive care unit on the 4th floor at Rhode Island Hospital. The the Miriam Hospital currently has 14 COVID critically ill patients in their unit, and they've spilled over to across the hall, what they call their surgical step-down unit for the non-COVID critically ill patients. And just today, we made the decision to prepare to go to our 4th COVID intensive care unit. And harking back to what I said earlier in this talk, it's not because we're seeing an influx of critically ill patients from the community as much as it is, and I showed you the numbers, we've got about 36 new COVID critically ill patients admitted to the Rhode Island critical care units over the last 10 days, but only 10 of which over 10 days have actually been through the emergency department. So clearly, and this is the well understood natural history of COVID-19, is people stay in the hospital for a long time, deteriorate late, whether it's on high flow oxygen or on mechanical ventilators. And this more recent internal surge, so to speak, is consistent with that. And you can see here, not to belabor it, but we have plans to go to the rest of the intensive care units. And this is the final maximum surge plan as requested by the Rhode Island Department of Health. And essentially you can see that our current plan is to turn the entire main building of Rhode Island Hospital into one large COVID intensive care unit, preserving a small non-COVID medical intensive care unit on the 4th floor of the main building. But you can see here that we intend to go to the 6th floor, 7th floor, and so on, so that at the end, and hopefully I showed you the modeling that now demonstrates a flattening of the curve, but just to show you that we were planning for the ability to handle 313 critically ill patients at Rhode Island Hospital. And I'll just end my piece here with some of what I see as the positive aspects that have come out of all of this surge planning and caring for critically ill patients. It's been remarkable, the collaboration across disciplines, both across between medicine and surgery and respiratory therapy and all the allied healthcare workers in the critical care units, and across medicine to surgery. There's been a remarkable stepping up to the plate from all disciplines, and people doing it in a very inspiring way and coming to work every day and being professional. And really, frankly, we all go through our periods of being exhausted, but there's been a remarkable degree of good cheer that I've seen in all 3 COVID ICUs at Rhode Island Hospital and the COVID intensive care unit at the Miriam. And just as important, there's been a remarkable degree of collaboration between Brown medicine and Brown surgery and lifespan in general. And finally, as I just said, the way in which the division, my pulmonary critical care and sleep division, has come together and spent time with each other and supported each other has really been wonderful for me to see. And really the small but real silver lining in all of this pandemic surge planning. And with that, I'll turn it back to Jay.
A couple final comments just about surge beyond existing capacity. As Mitchell pointed out, the ultimate ICU plan was for a significant part of the hospital to become an intensive care unit. And so the state had plans to expand hospital beds because those models that Mitchell went over at the beginning called for having more hospital beds than existed in the state of Rhode Island. And so the state of Rhode Island requested 3 alternate hospital sites. The goal was to care for lower acuity patients as an alternative to a traditional hospital, or transitioning those patients out of hospital when they had gone through the most serious part of their stay. These would be staffed and supplied to provide equivalent care to a general hospital ward. Lifespan has been responsible for 1 site at the Rhode Island Convention Center. There are some pictures here, one from above showing about half of that area in the convention center, and the one on the right showing a typical room or a ward with a number of beds. What's hard to see there is that each of these beds has an oxygen hookup because that's the single most effective treatment available for COVID. A lot of credit to the team that built this. Dr. Slim Sooner from our department, Dr. Kathy Duquette from Lifespan led this effort on behalf of Lifespan, the Rhode Island National Guard, NEMD architecture firm, DeMeo Construction, and the governor's office worked literally around the clock. A decision was made to build this on March 25th. Construction started on April 5th. Construction was complete 13 days later, and it was ready for patient care on the 25th. So I think, people a couple months ago were amazed when in China they built a new hospital in Wuhan in 2 weeks or something like that. Hopefully seeing this will make people feel faith that here locally we can have the same response. And the second thing I'll say is that while at this point it does not look like we need this facility, it is really important that we went ahead and built it. At the time the decisions needed to be made for all of this surge planning, the best evidence that we had was that we would use them in some capacity. And as Michael Ryan, who's the executive director of the WHO, has said, the greatest error in pandemic response is not to move. If you need 100% accuracy before you move, you're going to get it wrong. And if we had had a surge and didn't have the plans that Mitchell went over in this field hospital, then there would have been tremendous suffering. And I think we've seen that in a few areas. This is, I think, is our last slide. And I think I'll make a couple comments, but I think this applies for both of us. And really, now that we're at somewhat of a steady state, taking care of plenty of patients, what steps do we need to resume regular hospital operations to get to something that's more normal? The two things that I'm thinking about are we need a more rapid, more accurate point of care test. The more accurately we can identify people when they show up to the healthcare facility or even beforehand and know they have COVID, we can then sort them into different physical areas. That will decrease the risk of us transmitting COVID from one patient to another in the healthcare facility. It will decrease the risk of healthcare workers getting infected, and it will allow the overall healthcare system to do what it was able to do before. The second question is, how are we going to isolate COVID patients? Short of a vaccine, I personally don't see us getting COVID to completely go away. And so we're going to have a future where we have to care for these patients and do it in a way that's safe for other patients and staff. And figuring out how to do that while doing all of the other things that we want our healthcare facilities to do, care for sepsis, stroke, heart attack, cancer, et cetera. So Mitchell, I'll let you give your final thoughts on that.
I agree with everything you said. I think we've tried to highlight a little bit probably the most important thing being the success of flattening the curve. I know I feel, and I know Jay feels this way, I'm incredibly proud of the efforts of that Lifespan's done to close down visiting hours early, to encourage, to enforce masks for all the staff. And I think a lot of what we've done, not just in the state, but also in partnership with Lifespan and between all of the disciplines involved, really gone a long way to keeping healthcare workers safe and to keeping the state safe. So I've been very proud to be part of this team. That's too numerous to mention, but I again thank you all for the invitation. Thank the Dean and Sharon for the invitation, and look forward to taking any questions.
I went through the chat at the beginning, and I'll get a couple of those questions. So one was around the article by Rich Levitan in the New York Times about a week ago about the importance of pulse oximetry. And the question was, is it an important resource? So Mitchell, I'll let you start out with that.
I think that unfortunately there have been a number of pieces written by physicians in New York City that perhaps reflect the incredible strain that they've been under and grief that they've been under, including a piece about high altitude pulmonary edema. Pulse ox we don't know how many people die suddenly at home, but we also don't know in any way that monitoring your oxygen saturation regularly at home would lead you to come to healthcare facilities earlier. We see a lot of people who come and their shortness of breath is completely consistent with their hypoxia. So the assumption that people are dramatically dyspneic and short of breath, that they're hypoxic long before they get dyspneic and short of breath is just simply not true, or I should say is not proven.
What I should have given a little more context. The article advocates widespread distribution of pulse oximeters as a way to prevent patients from either dying at home or coming to the hospital. And I think the comment I would just emphasize is that we're seeing different impacts of COVID on the healthcare system. While we've seen lots of patients, I don't think we've been overwhelmed to the point where we can't care for them in the emergency department, where we can't admit them to the hospital. And some of these experiences coming out of New York, that has been the case, where literally they've not been able to unload patients off the ambulance. And so the advice out of there may not be the best for everyone if there is capacity in the system. There was another question about having different procedures for nursing home residents on scanning and arrival than for other patients. And I can just speak from the emergency department that our approach to patients from skilled nursing facilities and other congregate living settings has evolved as we've learned how prevalent COVID has been in those settings. And so as testing has become available, we have used that testing widely and now routinely test every patient from a congregate living setting. And it's required to get that testing before we can have them go back to their facility. And that's definitely the right thing. And figuring out, I don't work in skilled nursing facilities, but have had some experience. And that same question about figuring out how to care for those patients in those settings is going to be a key next step in this pandemic. Mitchell, other thoughts about?
No, I think there's a good question about the difference in porosity between the more opaque white body covering PEE versus the translucent yellow gowns. And I think if by white covering you mean literally the white suits that we've seen with hoods, we don't use those at all. I have a lot of confidence in the level of PPE that we use, which is both the kind of plastic gowns and the paper gowns, along with an N95, a full face shield, and 2 pairs of gloves for going in rooms. We have, as have many, I talked to a good friend of mine, Nikhil, quite a bit, and we've had a remarkably low transmission rate to healthcare workers. And I've seen people early on in this illness come in with outlandish looking PPE in the belief that this was equivalent of Ebola and they needed full, complete protection. And I really feel that we've held clear to the guidelines recommended about PPE under the guidance of Len Mermel, and we have not seen very much, if any, a transmission to healthcare workers. Of course, we've seen some, but even in the cases that we've seen, it's not been completely clear whether that's been community acquired or healthcare facility acquired.
The comment I'll just make about PPE is I also have very good faith in the decisions that have been made about what we've used. I think it is really important to acknowledge the anxiety of frontline providers who have heard cases from around the country, and often cases know people who have become quite ill and some people who've died from this. And so it's been a real challenge just to so rapidly change our protocols and make sure that people can feel comfortable with that. In our department, we have a number of faculty in the Division of Global Medicine, Adam Levine, and others who have worked on setting up Ebola treatment camps in prior epidemics. And what they brought to us was the importance of those protocols and the physical cues, that the exact type of mask is important in some diseases, but much more important is how you're putting things on and taking them off, and that you're not contaminating them when you leave the work environment to then go eat a donut. Because if you've got the best equipment on, but if you've contaminated yourself and you then go and then touch your face or something, that defeats it all. And so there's been work throughout the facilities to try to put those practices into place, and I think that's been a positive step.
Yeah, there's a question about have national guidelines influenced algorithms of care, and we've, having been on a couple of the national panels, we've developed algorithms and protocols at Rhode Island Hospital and the Miriam, and actually at the state, because I know that they've been shared widely by other hospitals, that completely are based on the algorithms developed for both the Surviving Sepsis Campaign guidelines and the HHS/NIH guidelines. So I feel really good about the fact that the care that we're providing is based on, it's hard to say evidence-based, because there is no evidence, as we know, but at least consistent with national guidelines. Someone else also asked what trials are going on in Rhode Island. So we know the remdesivir trial is still ongoing, actually. We have a trial that's about to start for IL-7. There is a trial in planning for an anti-PD-1 antibody. We do not have the monoclonal antibody against IL-6 going on in this state. We have a couple of other trials, one on a TREM1 inhibitor. So there are a number of trials planned or up and running. The one thing I will say is it tends to take so long to get these trials through the IRB, and the challenge of gaining informed consent, especially in the critically ill, are going to make it likely that by the time we have all of this worked out, there, I hope this is true, most likely won't be enough patients to enroll in these trials.
There was a question about unexpected barriers, and I'll take that just as a chance to talk about what has been unexpected so far. And I would say from the emergency department, the thing that's been most unexpected has been that drop in volume. I think we all expected typical emergency departments to volume to occur, and then these patients to come on top of that, and that we'd be dealing with a surge and how to physically deal with that. And the thing that's now quite surprising is that for conditions like stroke and heart attack and other conditions, we know that those conditions have dropped by a third or a half. And some of that can be explained by people not being at work, perhaps not doing some activities, but it does not explain all of it. And we've, at this point, tried to make sure we tell the public it is safe to come to the emergency department if you have those symptoms. Our cardiology and neurology colleagues are saying the same message. But that's, to me, been the biggest surprise.
There is a question on the dialysis and CRRT. So early on, having heard the stories from New York, I know in New York and talking to friends, there was a shortage of dialysis, and in several places like Mount Sinai and Bellevue and NYU Hospital, the Langiona Hospital, they were going to peritoneal dialysis early because there was a shortage of both intermittent dialysis machines and continual renal replacement machines. So we early on put an order in for extra continuous renal replacement machines. So we have yet to experience any shortage, but it is true that, and this has been reported in New York, there's a very high percentage of renal failure in these folks. In New York, it's been reported up to 30%. And so we're using a fair amount of continual renal replacement therapies.
There are a couple questions on testing, and one clarification I want to make is that in early April, 7 to 10 days into April, the hospital testing capacity greatly improved, but is not perfect. We are still seeing supply chain issues with testing, particularly around rapid testing. And so there are daily calls that we've all been on for months, and there are times when we are not having as much test reagent and kits available, and we have to change what those protocols are. So I think we'd probably be in agreement that anything we can do to get more availability of testing in hospitals, outside of hospitals, would be good. And if that does not increase rapidly, that's saying that the state could have some help in terms of figuring out how to make sure that that is equitably used in places like nursing homes and other congregate living facilities.
Yeah, there's an interesting question about would limited random community testing from the outset have made the predictive models much more accurate? I don't think so. I think that, as I said in the beginning, part of the reason for the need for predictive modeling was because of the lack of herd immunity. And so even if there had been limited random testing going on around the state, we might have been able to limit the exposure for family members and other people, but I don't think it would have made the predictive modeling any more accurate.
There was a question around coordination around the state. I'm not personally involved in it. Dr. Slim Sooner from our department has been on the state. And I think there is a coordination, but I think the important thing to remember is that up until 10 days ago or so, the expectation was that everywhere would be overwhelmed. And so the main coordination was in building these surge facilities. It now turns out that luckily we're not overwhelmed, and so there's more opportunity to coordinate with the existing facilities, and I think that'll continue.
There was a question earlier about coordination with Care New England and the VA, and a couple of things I should mention. I was at the opening of the surge facility here that Jay showed a number of pictures of in the Dunkin' Donuts Center, and it's really remarkable. And I've heard Dr. Babineau talk about this quite a bit. The degree of collaboration between the two healthcare systems has been remarkable, and who knows what will come out of this. I was on a town hall meeting with Dr. Babineau, myself, Dr. Mermel, and Dr. Murphy, et cetera, a few others, Kathy Duquette, and somebody asked Tim Babineau if, as a result of this, Care New England and the Lifespan were going to merge, and he laughed and sort of said, one step at a time. We should appreciate the fact that they were able to collaborate well enough to build the surge facility. I will say that my colleagues at the VA have really been incredibly helpful in helping the faculty and the fellows meet the surge demands at the Lifespan Hospital. So they have been willing to cover for the fellows who are assigned there at the VA by stepping up and helping cover for them and allowing the fellows to meet the surge demands at both the Merriam Hospital and the Rhode Island Hospital. And that's greatly appreciated, needless to say.
Dr. Rounds, other questions that we missed?
No, I think you did a fantastic job covering a very complicated area, and thank you so much for taking the time to do this. And Jack?
One of the things that I thought was very interesting from the talk by Cat Powell was his discussion of people who seem to be chronically ventilator dependent. Are we seeing the same thing here? He talked about almost 50% of the patients being chronic ventilator dependent. Do we have that going on right now?
Well, yeah, it's a great question, Jack. The problem is we're 2 months into this. And so I was reporting, so our current ventilator mortality statistics at Lifespan, our mortality is 40%. So unlike what we're hearing from New York State, which I think was New York City, the Northwell system in JAMA reported an 88% mortality. So we now see that we have a 40% mortality, but the truth is a lot of these patients are extubated, but still in the hospital. So I don't really know what our survival to discharge will be. And I don't know what the chronic vent dependence is, but I will say that we've only trached, so we've been doing this for 2 months, and we've only trached 2 patients so far. So it doesn't look like we're going to see that level of chronic vent dependence.
So let me just echo what Sharon said. Thank you both for putting this together. A tremendous talk, a tremendous performance by your teams and yourselves. You talked about being proud of being part of that team. We're proud of being distantly related to your teams. So thank you very, very much for everything you've done. Thank you.
Our pleasure. Thank you.